there we go. All right, good morning, everyone. My name's Dr. Harnain. Thanks, Dr. Desai, for that introduction. So I'm talking about Angiojet for DVT. These are my disclosures. So what is Angiojet? It delivers high-pressure saline jets through the tip of a catheter. The jet travels backwards, creating a low-pressure zone. This allows for thrombus to be suctioned into the inflow windows. There's a power pulse feature in the Angiojet, which allows for the infusion of thrombolytics at the site of thrombi. This sort of distinguishes from a lot of other catheters that we'll be talking about, the ability to deliver thrombolytics at the site and in the vessel. There are two sizes of catheters. The first one is the Zalante DVT. It's an 8 French catheter designed to treat veins greater than 6 millimeters. And then there's the Solent catheter, which is a 6 French catheter designed to treat veins greater than 3 millimeters. So I use the Solent for tibials and going into the POP, and then the Zalante for iliofem DVTs. There are a couple precautions that you have to take into consideration when using Angiojet. There's a black box warning for reolytic thrombectomy, which is what Angiojet does for PE treatment. So the release of adenosine from disrupted platelets can lead to bradycardia, pulmonary vasospasm, and worsening hypoxia. And then you can also get this hemoglobinuria from the destruction of red blood cells by the high-pressure saline jets. The degree of this hemoglobinuria increases with the extension of operation time, so you have to, and that leads to renal dysfunction. So you have to be careful of how much you're running the Angiojet through your veins, and be cognizant that the patient may have hemoglobinuria. The urine may have be blood tinged at the end, and their CMP, BMP may be abnormal after the procedure. So really the Pearl registry was the landmark study evaluating reolytic thrombectomy and Angiojet. This was published in 2015. And so what it says, so there's two arms. There's one arm for arterial studies, and then there's Pearl DVT, which is a subset of the study. So they looked at 371 patients. 34% of the patients were treated in a single session, and then 87% of patients had 2 or less lab sessions. Most were done in less than 24 hours. This is the time when we used to do multiple sessions. Now I think everyone most likely is using single session. Less total lytic used when delivering the Angiojet than if catheter-directed thrombolysis were included in the treatment, with final venographic results comparable in all subgroups. They treated 1,295 venous vessels, 97% showing improvement, 3% unchanged, and less than 1% worse. So if you look here at this graph, reolytic thrombectomy, which is Angiojet alone, 100% improved. If you just looked at pharmacomechanical thrombolysis, 97. So pretty much if you look at all different types of treatment algorithms, there wasn't really much statistical difference in baseline occlusion. The difference seems to be in physician treatment, what catheter you want to use. So Angiojet is effective. So 3, 6, 12-month freedom of rethrombosis was 94%, 87%, and 83% respectively. There's about 4% major bleeding events, but none related to the Angiojet specifically. There's been a new advancement in Angiojet with the addition of Clot Hunter. I'll go into that in a second. So this 60 to 80% increased thrombus removal with Clot Hunter compared to Zalante DVT alone. So what Clot Hunter is Angiojet traditionally has been over the wire. Once you have access through and through, you run the Angiojet, and you don't have to give up wire access. But that sort of limits the amount of clot that you can take and vessel apposition. So the Clot Hunter is, let me go back. The Clot Hunter is basically you lose your wire access, and then there's a helical wire that gets advanced into the catheter, and that allows for 330-degree opposition of the vessel and allows to get really good thrombus removal. I'm not sure if anyone from the panel has used Clot Hunter. I haven't specifically used it, but it's had really great results compared to just using the Zalante alone, and it's really pushed Angiojet in line with other devices that are now on the market with large bore access, such as the Penumbra and Inari. So I'll go through a case. This is a 24-year-old with lower leg extremity swelling. 3 days post-workout, the ultrasound showed extensive occlusive thrombus throughout the left lower extremity. The CT demonstrated a May-Thurner syndrome, evidence with thrombus throughout the visualized left common femoral, internal iliac, and external iliac, going down to the common iliac veins. And you can see that the vessels compressed between the iliac artery and the spine. So here's our initial DVT, our venogram showing extensive acute DVT. Here's once we got through that, we ran the Zalante catheter. So you can see these two radiopaque markers going up and down. That's the angiojet going through. This is not with the clot hunter, so it runs over the wire, which it has an advantage over other catheters where you can run it over the wire and it still works pretty well. A lot of the other devices, you have to give up wire access to get really good results. So once you run this angiojet over, this is supposed to be a video, but it's not playing. A lot of the clot got removed, and the patient did well. We angioplastied it here. Here's the run after angioplasty, and then after that we placed the stent, and the run shows pretty brisk flow through that lower extremity, and no more venous deep venous disease. Any questions? All right. I think next we're going to Dr. Ahmad with penumbra.